Okay, good afternoon, everyone. My name is Maura Canavan, and I am with the Community Health and Wellness Department at Suburban Hospital. Today, we are here to discuss atrial fibrillation with Dr. Zeshan Ahmad, Director of Complex Cardiac Ablations. We will have time for questions at the end, so please feel free to send them in the Q&A box as they arise. And after the webinar, you will receive a link to an evaluation, and we really appreciate your honest feedback as it helps us as we continue planning for more community programs. This webinar will be sent out and recorded and sent out in the coming days. So thank you all for being here this afternoon, and I will now pass it along to Dr. Ahmad.
Thank you, Maura, for having me. It's a pleasure. Hopefully you guys can all hear me. It's a pleasure to be here this afternoon with you guys. Hopefully you guys are getting some sun. Obviously, I'm in my office, so I'm getting artificial light, but it's better than nothing, I guess. I have the pleasure of talking to you guys about atrial fibrillation, as well as some advances in electrophysiology, which is the field that I specialize in, which is the electrical conduction of the heart, essentially. So we'll kind of talk about what the basics of electrophysiology are, and then we'll kind of go into in-depth more so into specifically atrial fibrillation and some other treatments that we're doing, cutting-edge treatments that we're offering at Suburban Hospital and for our local patients in the DC area as well too. So let me get going. Might be some technical things. There we go. So what is electrophysiology? Essentially, what we're dealing with is the electrical conduction of the heart. So the actual heartbeat, the pulse, whatever you want to call it. Electrophysiologists deal with the treatment of fast heart rhythms as well as slow heart rhythms. And so you might hear terms such as bradycardia. Bradycardia is just a term meaning slow heart rhythm, and tachycardia means fast heart rhythm. And so what we're going to do is talk about what we do to treat each of those specifically. And first, we'll kind of focus on the slow heart rhythm portion, and then we'll go from there. So how do we treat slow heart rates? Well, technically, if you're symptomatic from a low heart rate, we plan on putting in a device called a pacemaker. And these are pictures of traditional pacemakers. I don't know let me see if I can show you. I have a laser pointer. Hopefully that helps. Can you guys see my laser pointer?
Yes, we can.
Thank you. So these are traditional pacemaker systems. So this is a pacemaker here. These ones here are defibrillators, and the way we can tell are that the defibrillators have a thicker coil. That's for the shocking, in case a heart needs to be shocked for some life-threatening heart arrhythmia. But essentially what it is wires, actual wires that are placed into the heart themselves. So one wire goes into the top chamber of the heart that we call the atrium, and then another wire usually goes into the bottom chamber of the heart called the ventricle. And that's the main pump of the heart. When we talk about a heartbeat, that's usually what's generating that heartbeat, essentially. And so these are just different manifestations. So this is a pacemaker here. This is a defibrillator here, and you can see the shocking coils, these brighter points right here. And then this is what we call a biventricular device, meaning this has 3 different wires, and those are pointed out by the arrows carefully placed right there. So you have one wire going up into the atrium. You have one going into what we call the right ventricle. That's actually in this situation is a defibrillator. And then you have another wire that's coursing through the outside of the heart onto the left side of the heart right here. And that allows for resynchronization of the heart in case for some reason the heart is asynchronous for any reason or dysynchronous. We're trying to restore that synchrony in order to improve the heart output or cardiac output, essentially. Recently, though, there's been a great development, and that's leadless pacemakers. And that's something that we are on the forefront of. We're putting in at Suburban Hospital. We've had many implants. There's 2 main devices, and I'll talk about them quickly, but essentially the benefit of the leadless pacemaker are multiple-fold. One thing is patient comfort, so not having a device that's protruding out of the skin sometimes, not having those wires, in essence, not having the incisions that needs to be made. Essentially everything goes through the blood vessels of the groin, and you deploy the device through a sheath that we put up into the heart over a wire. It's pretty straightforward to deploy most of the time. There are certain instances where it might be a little bit more complicated, but for the most part, really haven't run into too much issues with implanting these devices. Long term, so a typical pacemaker lasts from anywhere from 8 to 12 years, depending on how much we use it. In these situations, a leadless pacemaker can last up to anywhere up to 18 to 22 years. So, you can get more bang for the buck, and less need for having to exchange out the battery, which you don't have to do as much with these leadless pacemakers. Also, for patients who are renal patients or on dialysis or have an increased risk for infection, these devices have a lower profile. And because of that lower profile, it leads to decreased risk for having an infection that could be related to the device itself. The things about the traditional pacemaker system is that it's in the bloodstream itself, it's in the blood pool, but it also has exposure to the outside. And so this exposure to the outside to the inside can promote infections of the heart, including the heart valves. We call that endocarditis. And that most of the time requires a surgical intervention, including removal of the pacemaker system. Whereas the leadless pacemakers, and I'll show you a picture of those soon, you kind of prevent that as much as possible. And it's probably going to be the new future of pacemakers in probably the next 5 to 10 years or so, as we kind of go up on the number of implantations that we're doing. So to kind of show you what this looks like, I'm just going to move this a little bit to the side. So these are the two main types of leadless pacemakers. The top one is made by a company called Medtronic. It's called the Micra, and it's only what we call a single chamber. So there's only one device that's deployed. And you can see comparison to the size of a nickel, it's very, very relatively small, essentially. And it has these hooks which kind of open up into the heart tissue itself, and that's how it kind of grabs onto the tissue and is what makes it stay in place, essentially. The other system right here that we see is called the Aveir. It's made by Abbott, a company called Abbott. It used to be called St. Jude. And the reason why you see two different sizes is because they have kind of they kind of mimic a traditional pacemaker more so than the Micra does. And let me kind of go back to a picture to show you what a traditional pacemaker looks like. So you see you have two wires. One goes into the top chamber of the heart here, and one goes into the bottom chamber of the heart right there. These leadless pacemakers are mimicking the same thing, but they're just using a leadless device. So you have one that's in the top chamber of the heart right here. If you can see that, it's kind of faint, not the best image. And then you have one in the bottom chamber of the heart here. So it's acting like that traditional pacemaker, but without all the wires and the batteries, because everything is self-contained. And what happens is these two devices actually communicate with each other, and that's how we get the synchrony back, essentially. So it's a great kind of advancement in pacemaking technology, and we're happy that we have the ability to do this at Suburban for the local community. Now, this is a comparison side-to-side profile of the traditional pacemaker. As you can see, here's the battery and the programming apparatus for the pacemaker. They're the two wires that are going into the blood vessels here, and then going down into the heart. You have the one wire here, and you have the one wire down here. You can see how extensive this device system is. And going on to the next picture, that's the leadless pacemaker right there. Everything's self-contained. It does the pacing, all the battery, everything is self-contained into this little device. And you see how much less material there is, foreign material there is in the body that can be at risk for infection in the future as well too. So that's one great thing about what we're doing at Suburban, essentially. Any questions so far? I can take some right now, I think, because we're going to be switching over to treatment of the fast heart arrhythmia issues. So if there was anything with regards to leadless devices or pacemaking in general, I can answer them now, or we can kind of move on to the next section and wait for everything at the end. Pull that back up.
I don't see any questions at this time.
Sorry, was that someone asking, or should I just keep going?
Oh yeah, I don't see any questions at this time.
All right, perfect. So we'll move on. So how do we treat fast heart arrhythmias or fast heart rates, essentially? So multiple things we can do. First of all is we can try medications. Maybe a lot of you have heard of a medication called amiodarone. It's kind of the best medication to treat different various heart arrhythmias, including atrial fibrillation. But it is associated with multiple systemic side effects, and one of them is affecting the thyroid gland. It can cause liver damage, it can cause lung damage, pulmonary fibrosis. It can cause eye issues such as cataracts or other manifestations, hemorrhaging of the eyes as well too. And so a very rare side effect, but it can happen. And then previously what we were able to do is also electrically shock you, but this is only a temporary fix. It doesn't really fix the underlying issues. It's to get you back into normal rhythm in order to continue on, but it doesn't prevent you from going back into said heart arrhythmia, whether it's atrial flutter or atrial fibrillation. So these two treatment arms, this is the more long-standing treatment, has a lot of side effects. The more short-term treatment really is only a temporary fix. And then the reason why I attached this patient is because this is a patient who's been on amiodarone for quite some time, and it infiltrated into his skin and turned it kind of this gray bluish color. I've had one patient back when I was in Houston training who actually had this manifestation, and that was after about 20 to 30 years of being on amiodarone. So he was in normal rhythm, but he had this skin color. And what happens is that the amiodarone actually infiltrates the skin, and when you're exposed to the sun, it can start causing these issues long term. So I use amiodarone all the time for short duration, but I think long term I try to avoid it as much as possible. Now, going over the most common heart arrhythmia in the world, atrial fibrillation, more than 30 to 40, probably getting closer to 100 million people are probably affected by this. It increases your risk of stroke, it increases the risk of heart failure, and it can even increase the risk of vascular dementia. Any one of my patients who I talk to about atrial fibrillation, I always kind of harp on those are the three things that we're really, really treating, is to decrease your risk of stroke, to decrease your risk of developing congestive heart failure as a result of atrial fibrillation, though you can have heart failure for other reasons, and to lower that risk of dementia. And these are kind of nebulous things that it's kind of hard for some patients to grab a hold of, is like, what am I really trying to prevent by being a little bit more aggressive with my management of atrial fibrillation? Well, what we're really doing besides treating your symptoms is really preventing all these things from happening as much as possible. So the risk of stroke is increased in patients who have atrial fibrillation by an increased factor of 5 to 9 times that compared to those who don't have atrial fibrillation. The risk of heart failure is up by about 2 to 3 times compared to those who don't have atrial fibrillation. And the risk of dementia, which is kind of more insidious, is about 2 to 3 times the increased risk compared to those who don't have atrial fibrillation as well. And this has been a phenomenon that we've really discovered in the last 10 years or so. And so there's more and more literature that's coming around about dementia as a side effect of atrial fibrillation. Besides that, there's also the emotional burden of having to, go into the hospital to get a cardioversion, or just the fact that sometimes you feel a little bit down or fatigued or tired. That can all add up to the emotional burden as well as a financial burden of treatment of atrial fibrillation. This is kind of a cost that's spread across the entire United States, essentially, when it comes to treatment of atrial fibrillation. The treatment for a stroke per year is around the order of almost getting on to almost 80 to 100 billion dollars. The treatment cost to the United States for heart failure is almost on the order of almost 100 billion dollars as well too. So if we can prevent those as much as possible, it's also cost savings long term for the entire population. This is kind of the treatment. This is kind of the progression of atrial fibrillation. And so what you see is the black parts are when the patient is in AFib, and that's maybe something that some of my patients experience. And this is kind of earlier on, what we call paroxysmal, or more the milder form. They have short runs of AFib, they go in and out of it. It gets a little bit more and more sustained, and have more and more frequent episodes, and then it gets to a point where it becomes more and more persistent, or more of a moderate form. And here they might need electrical cardioversion. So that's what these little lightning bolts represent, is every time a patient's been shocked. And you see it lasts for a while and then it starts back up, and then you go back in, and then you go back into it, and you need another shock to get you out. But every time you get shocked, it doesn't last as long. And then we get to a point where it becomes permanent. And that's what we're trying to avoid as much as possible. Though a lot of patients do live in permanent AFib and they're doing well, there's a lot of patients who don't tolerate AFib at all. And that's because they might have a stroke, or they might have congestive heart failure for other reasons besides the symptoms as well too. So what we're trying to do is prevent the progression of atrial fibrillation long-term into more permanent, persistent courses. And so if we can get to patients when they're in this paroxysmal phase, or the more milder form, it's a lot easier to treat than it would be later on during their treatment, during their disease course, essentially. So what causes atrial fibrillation? Well, the primary AFib is what we call lone AFib, and that happens in about 5 to 10% of patients, where there really isn't a secondary cause for atrial fibrillation. We do think there's genetic factors that are involved, but there are no genetic treatments as of yet that are targeted towards the treatment of atrial fibrillation on a genetic level. Mostly AFib, anywhere around the order of 90–95% of the time is due to other causes, whether that's uncontrolled hypertension, whether that's obstructive sleep apnea, and they may need a apparatus to help them with breathing, essentially. And sleep apnea is not snoring. I think that's a misnomer. It's actually the lack of breathing. And the reason of that is because the lungs and the heart are interconnected. And so if you put pressure on the lungs, that's going to transfer to the heart and cause the patient to go into atrial fibrillation. Obesity, which is a common, unfortunate thing in the United States, and it's increasing, has been linked with an increased risk of atrial fibrillation as well too, and that could be because of the pressure placed on the lungs as well too. Heart failure, and then this is, is it the chicken or the egg? Is the AFib causing the heart failure, or is the heart failure causing the AFib? Either way, when you have a patient with heart failure and they develop atrial fibrillation, the risk for them increases. And so trying to control AFib in the patient with heart failure has become one of the main things that we as electrophysiologists who specialize in atrial fibrillation are trying to really stamp out as much as possible, whether that's with medications or with a procedure called an ablation. If they have valvular disease, mainly mitral valve disease, but any kind of valve disease can lead to an increased risk of atrial fibrillation. And risk factors, so not just alcohol that I'm going to harken on, but caffeine intake, things like that. If we can minimize them, we can hopefully decrease the risk or the recurrence of atrial fibrillation as much as possible. And then some metabolic disorders, such as the thyroid gland. So if the thyroid gland is either too high or too low, mainly if it's too high, meaning there's an excess of thyroid, then that can cause patients to go into atrial fibrillation. And the treatment course for that is actually treating the underlying thyroid issue more so than treatment of the AFib specifically. If we can treat the thyroid gland, then we can kind of control the atrial fibrillation in that instance. We're going to talk about stroke briefly. So we have a stroke risk calculating calculator that we use to see what the risk of your yearly score for developing a stroke while having atrial fibrillation is. We call that the CHA2DS2-VASc score, and it uses various factors, whether it's age, whether you have a history of congestive heart failure, high blood pressure, diabetes, you've had a stroke in the past, whether you have coronary disease or carotid artery disease, plaque buildup within the blood vessels of the neck. All those factors are increasing risk factors for developing stroke. And so if we can minimize that risk by putting patients on a blood thinner or deploying a device called a left atrial appendage occlusion device, such as the Watchman device here or the Amulet device here, we can decrease that risk of stroke with a small surgical procedure if they don't tolerate a blood thinner. And we do these at Suburban as well too, mainly the Watchman, but sometimes we do the Amulet as well. Now, talking about non-medical or options for the treatment of atrial fibrillation, we're going to talk about catheter ablation. That's the main reason why I've been brought to this area, is to improve the catheter ablation treatment for atrial fibrillation. So what that entails is putting up different catheters. So catheters are just wires with different electrodes at the end. And what we're doing is, first of all, making a 3D map of the heart. And we do that with these mapping catheters here. These are high density mapping catheters. So this right here is Penraid's from one company. And what it does is you put that into the certain part of the heart where atrial fibrillation comes from. And we can make a real-time 3D map of the heart that includes the anatomy as well as the electrical conduction of the heart. And we can look for scar tissue as well too. And all those things in line allows us to do a successful ablation of the areas where that are trigger points for atrial fibrillation as much as possible. And these are just different various mapping catheters that we used to use, but we don't use as much anymore. Mainly we're using these high density mapping systems more so than anything. And then this is the ablation catheter itself. So this is a radio frequency ablation catheter. And what it entails is radio frequency, so energy applied to the tissue. And we have grounding pads, so it sends a signal, electrical stimulus that causes heat to generate around the end of the catheter. And what we're doing is essentially burning within the tissue. And this is kind of pinpoint, point by point ablation, essentially. So we're going around kind of tack marking or tack welding, essentially, around those certain areas of the heart where atrial fibrillation comes from. And what we're trying to do is cause a line of scar tissue to form so that that signal that are from the high trigger points for atrial fibrillation cannot get into the heart anymore. There are different types of catheters. So this is the radiofrequency or burning catheter. There's also a cryoballoon, which is freezing. And then there's a newer technology that's come out recently, and that's called pulse field ablation. And this is supposed to be quote unquote non-thermal, so no heat or no cold, but what it is providing an electrical stimulus that causes programmed tissue death to occur in order to form a line of scar around those areas where AFib comes from. And what this allows us to do is to be a little bit more aggressive without causing any kind of more collateral damage to structures around the heart, including the heart or around the heart as well, too, that we get worried about when we're doing either radiofrequency ablation or the cryoballoon ablation as well, too. So these are kind of the pretty maps that we make real time. So as you see here, this is a chamber of the heart called the left atrium. This is looking at it from the back. So you can see right here, this is the patient's back. So we're looking at it from the back. So these are the four veins, pulmonary veins that come into what we call the left atrium. And those seem to be the main triggers for atrial fibrillation in about 95% or so of patients. And so when we're doing an ablation, what we're doing is isolating these veins so that that signal for AFib doesn't penetrate into the heart anymore, essentially. And so this is the same left atrium here, and this is another chamber of the heart called the ventricle. And right here, they're doing an ablation for what we call a PVC, and that's what I do up in Baltimore when I take a patient up there. We do PVC and ventricular tachycardia ablations as well, too. So that's kind of my brief presentation. Ready for any questions out there with regards to either if it's pacemakers or other heart arrhythmia issues, as well as atrial fibrillation and what entails a ablation procedure too.
Thank you so much, Dr. Ahmad.
Thank you.
Let's see if we have any questions. Please type them in the Q&A box if you have any questions. I can get started with one. You mentioned atrial flutter versus atrial fibrillation. Do you mind just expanding on that a bit, the difference between the two?
Let me pull up a picture. So let me go back. Let's see if there's a good picture of the heart that I have. So I know these are used for the Watchman, but it's a good representation of what the heart looks like. So we're looking at the heart from kind of dead on. So from my point of view towards the patient, essentially. You have the atrium, which are these two chambers here. This is the right side of the heart. This is the left side of the heart. And then the bottom chambers here are called the ventricles, essentially. And so atrial fibrillation and atrial flutter are essentially cousins of each other. They both increase the risk of stroke. They both increase the risk of developing congestive heart failure, and they both increase the risk of vascular dementia. Atrial flutter is more of an organized rhythm. It's kind of a circuit that forms either on the right side of the heart or this left side of the heart. 85% of the time, it's usually on this right side of the heart. And we can do a straightforward ablation of this. It's kind of an outpatient procedure. Usually takes about anywhere from half an hour to an hour or so. And what we're doing is doing an ablation from this valve right here all the way down into this blood vessel right here called the IVC. And what we're trying to do is form essentially a circuit breaker so that that circuit no longer can form, essentially. And so that's how we usually treat atrial flutter. It's usually more of an organized heart rhythm. Usually the heart rate in the top chambers of the heart called the atrium is anywhere from 200 to 300 beats a minute. Atrial fibrillation is a different type of animal in the sense that it's beating at anywhere from 400 to 600 beats a minute. And it's usually coming from this left side of the heart. So doing a circuit, breaking the circuit here wouldn't work because there's multiple points that it's coming from. And so what we do is do that ablation of the veins themselves.
Great, thank you. And if you don't mind just talking a bit slower, just for some folks on the call.
Sure, no worries.
Thank you.
I get so excited that I love talking about it. So I get a little too excited sometimes. You have to kind of tell me to slow down a little bit.
No problem. Thank you. So I guess just a follow-up question on that, then is the only way to detect between the atrial flutter and the atrial fibrillation by knowing the beats per minute, by seeing that, or is there another way to detect the difference?
So usually either an EKG, so go into a doctor's office and seeing if you do have them. Usually you can diagnose them based off of, you know, what waveform we see, whether it's atrial flutter, which is kind of an organized, what we call sawtooth pattern, versus atrial fibrillation, which is disorganized. And so we can kind of tell the difference between that. pay, anyone who's listening you can buy a device on Amazon and for about 80 to 100 bucks called the Cardia app. And it has its own small little EKG sensor on it, and that connects to a smartphone, and that can tell you with better estimation than say an iWatch or one of those wearable devices whether or not you are having atrial fibrillation or atrial flutter. And then you can send those images. I get them all the time for my patients who send me a little snapshot of their Cardia app showing them that, oh, it's telling them it thinks that they're in atrial fibrillation or atrial flutter. And then I kind of look over it. I'm like, no, it's probably a misdiagnosis. You're just in normal rhythm, or yeah, you are really having bouts of atrial fibrillation or atrial flutter. So the main way to tell the difference between flutter and AFib is mainly the EKG, but there are different ways of getting those EKGs now that are more available to all our patients outside of having to come to the office. So it's Cardia app, Kardia. You can find it on Amazon.
Great, thank you. And our next question, are there any downsides to a pacemaker?
There are downsides to a pacemaker. First of all, it's a foreign substance in your body, and sometimes there could be a reaction to it. It increases your risk of an infection, a bloodstream infection, something that we call sepsis. Maybe people out there have heard of that. The other thing is sometimes the wires can go bad, and we might need to replace them, or the battery needs to be changed out for whatever reasons. Either the battery has used up all its energy, or there's some other issue, or there's been a recall. So yes, there are downsides to having a pacemaker, but it depends on the patient and the reason why they need the pacemaker in the first place. Just because you have a low heart rate, if you're not really symptomatic, the recommendation is to kind of hold off and see if you really need a pacemaker. But then there are certain reasons you might need a pacemaker, and for those patients, we definitely recommend it. So it depends on the risk versus the benefit, and us as the physicians weighing that risk versus the benefit of a patient. Now, whether you need the traditional old device with the wires and the leads versus a newer device that's kind of leadless is really up to the physician at the time and what they think might be the best option for you. But that's a decision to make with your physician at that time.
Thank you. And what are the risks of an ablation? And is the procedure done in an outpatient facility?
Sure, yeah, great question. So an ablation procedure, let me pull up the picture. So it's typically an outpatient procedure. It lasts anywhere from, if we're talking about AFib specifically, is about anywhere from 2 to 3 hours. And this is done under general anesthesia, typically in the United States. Though once we get this newer technology, the pulse field ablation, it might be done under general conscious sedation more so than anything. That's what they do in Europe, actually. And so the total time is about 2 to 3 hours, like I was saying. It's generally an outpatient procedure. I would say about 97% or so of my patients go home the same day. Though we can keep you for various reasons, whether it's your heart rate's a little bit low or your blood pressure dropped a little bit more so than usual. Maybe there was some other reaction or an adverse outcome. The risk for a major adverse outcome is on the order of less than 0.1%. The risk for a minor complication, whether it's bleeding, bruising, or hematoma, because usually patients who have atrial fibrillation are on a blood thinner. And because of that, they're at higher risk of having these minor complications. That's on the order of 1 to 2%. So overall, it's a very safe and effective procedure. The long-term implications, though, and from the recent studies that we've seen, benefit of patients having an AFib ablation for paroxysmal atrial fibrillation, which is the more milder form of atrial fibrillation, is on the order of anywhere from 75 to bordering almost to 85, 90% freedom from atrial fibrillation at about 3 years. And that's, we say 3 years because that's how much the government paid for those trials, and that's the reason why we can say that. But we've had patients who are 5, 10, 15 years out of their ablation who've done really, really well. Other patients, they might not be the best candidate for an ablation, and they might have had multiple ablations. You might have heard stories of those patients who've had multiple ablations. I just want to let you know every patient is different, and so it just really depends on multiple factors to determine whether or not a patient would be a good candidate for an atrial fibrillation ablation specifically. And that's what you have to have a discussion with someone like me so we can have that discussion and see if you are a good candidate or maybe not the best candidate for an ablation.
Thank you so much.
Mm-hmm.
And how about what is the criteria for a Watchman?
So there's a scoring metric that we use. I think I mentioned it earlier. Let me pull up the page for the Watchman. So we use this a scoring metric called the Chad's VAS score, and like I said, it takes over a whole host of factors that a patient might have, and to see if they're at an increased risk of a stroke. Now, on top of that, there's also another scoring metric that we use to see what's their risk of a bleed as well too. And what we want are patients typically who have at least a Chad's VAS score of 3 or above and might be at higher risk for bleeding, or patients who want to get off a blood thinner that are usually candidates for a Watchman. Anyone usually that has a score of 2 or less is not generally regarded as a good candidate for a Watchman or a left atrial appendage occlusion device unless they've had recurrent major bleeding for whatever reason. And then those patients might be considered patients that are good candidates for a Watchman. But just a reminder, a Watchman does not prevent 100% of strokes. In the setting of the atrial fibrillation, it actually reduces the risk by about 90%, which is great because the area that we're plugging in is the main source for clots in patients who have atrial fibrillation. But it also means that 10% of patients might have stroke, might have a clot form in other areas, whether it's in this left atrium or somewhere else, that can still lead to a stroke. So the real benefit of a Watchman or a left atrial occlusion device, as we call them, is really to reduce the risk of bleeding more so than anything. It hasn't been shown to be superior in any regards to blood thinners like Xarelto or Eliquis or Pradaxa. It's all, the only thing it's been shown to do really is lower the risk of bleeding.
Thank you. That's very helpful. And so after the catheter is removed, after the ablation procedure, sorry, it's a question. Is the catheter removed after the ablation procedure?
Yes. So after we're done, what we try to do is re-induce the atrial fibrillation. If we can't re-induce the atrial fibrillation, remove the catheters completely out of the body. And then we place sutures on both sides or some kind of closure device in order to plug up the blood vessels. We usually go into the veins, not into the arteries. So we're into the low pressure pipes of the body, essentially. You usually lay flat for about 4 hours or so. And then afterwards, we ambulate you, we make you walk, make sure that the incision sites are not bleeding or oozing anything, and that you're able to eat or drink water at least before you're considered a safe candidate to be discharged home the same day. Now, for any of those reasons you don't qualify, then we usually keep a patient overnight, but it's in something called extended observation. So it's still considered an outpatient procedure, even if the patient has to stay overnight for one night.
Okay, thank you. So just to clarify, there's no mechanism permanently inserted.
No device is permanently inserted unless we're doing, something like this, like a Watchman or an amulet device, and that's just to get you off a blood thinner. So that, in essence, is deploying a device. But for an AFib ablation or any other ablations, typically we do not leave anything at all into the body.
Great, thank you. And please continue to ask these great questions. We have one more here. When will you know after an ablation procedure if it has been successful?
That's a great question. So I get this one commonly. So I think the expectation, and this is the physician managing the patient's expectation more so than anything, is the fact that, and I tell this to all my patients, whenever you get a paper cut, it turns really red and angry at first, and then it scabs over after a few weeks. The same thing happens after an ablation in the heart itself. So the first few weeks after the ablation, don't be surprised if you go into atrial fibrillation. The most common time to actually go into atrial fibrillation is after an ablation because of the inflammation that's stirred up by the ablation itself. And so once that kind of calms down, and we really see whether at the 3 to 6 month point, whether or not you still are having significant amounts of atrial fibrillation. Now, what is a good outcome, first of all, I think is what we have to kind of define. A good outcome with an AFib ablation, say if someone is in AFib 100% of the time, if we lower that burden from 100% to less than 20%, less than 10%, less than 5% of the time they're having AFib, that's a significant improvement in their quality of life, in decreasing those risk factors of stroke, congestive heart failure, dementia as well too, as well as their symptoms. And so, sorry, if we can reduce it from 100% to less than 5%, you might still have AFib here or there, but it's much more controlled and it's in shorter bursts and it's not all the time. And so in that essence, I think that's considered a great success. Some patients, I think they expect that once you do an ablation, your AFib goes away completely, and that's not the case. It's kind of like knee surgery. You have the knee surgery and then you have the rehab afterwards, but you can always injure the knee at some point in the future. You might need to readdress it at some point again with another surgery or continue to rehab or steroid injections. The same thing happens in the heart as well too. AFib is kind of like that. Some patients have 1, 2, maybe even 3 ablations for their AFib because there could be different areas where scar tissue forms, as you see on these models here. But that was a great question.
Thank you.
Like I said, 3 to 6 months mark is when we really find out if an ablation has been successful.
So is that common then to, do multiple ablations?
It can be common. Like say if we get someone pretty early on, like I ablated like a 55-year-old recently. He had paroxysmal or mild atrial fibrillation, and my hope is that he doesn't have to have another ablation for 5, 10, 15, 20 years down the line. It really matters though how he treats his heart and how he treats his body as well too. And that's the kind of rehab portion. So things that you can do to kind of help the ablation would be, losing weight. Even modicum weight loss really can be beneficial for a patient with atrial fibrillation. Exercising, avoiding certain triggers, whether it's alcohol, caffeine, all those things that can cause AFib to come around. Whether you've been diagnosed with sleep apnea, whether it's having a CPAP machine or some other device or implement that can help you with your breathing. All those things, if we can kind of manage those as much as possible, can really make the ablation a true success versus not. So it's kind of a mental change as much as it is just the ablation. I always tell the patient it's what you do afterwards that really is going to make this ablation beneficial or not. So.
Thank you. And that brings us a little bit into our next question. How important is the relationship between AFib and sleep apnea?
Very important. There's a positive concordance between atrial fibrillation and sleep apnea. And so those patients who have pretty moderate to severe sleep apnea usually have a high risk of developing atrial fibrillation. And my hope is usually first of all, is to diagnose them with the sleep study. And luckily the sleep studies are now more portable and they can be done at home. You don't have to go to a sleep center as much or as often as you used to. And if you have the diagnosis of sleep apnea and it's severe enough to need a CPAP machine or some other device to help you with your breathing, a lot of the times that can help with decreasing the burden of atrial fibrillation and other heart arrhythmias as well too. So it's important to find out if you do really have sleep apnea. And remember, snoring in itself is not a diagnosis of sleep apnea. It's really the lack of breathing, what we call apnea, that really can drive atrial fibrillation.
Thank you. Okay, and what are the criteria for selecting an EP to do an AFib procedure?
So if it's an AFib procedure specifically, you want to go to someone who is comfortable and does multiple AFib procedures a week. I'm doing on the order of 6 to 7 AFib ablations a week, whether they're at Suburban Hospital or up at main campus at Johns Hopkins in Baltimore. So if I have a more, more severe form of AFib or someone who has congestive heart failure as a result of AFib or other heart arrhythmias, I take them up to Baltimore, where we have all the bells and whistles that we would need to treat a patient like that. But if it's kind of your, what I call bread and butter, more mild form or moderate form of atrial fibrillation, more than happy to do them down here at Suburban Hospital as well too. But you want to go to someone who does a lot of these, not just someone who does a few of them. Whether with regards to whether they do freezing versus burning, that's a little bit more controversial. I think it just depends on the situation. I prefer burning, even though I did most of my research in the cryoballoon. If you do a lot of the research on cryoballoon, you should see my name in a few of those articles there. They're both great, I think. And if you are considered a good patient for an ablation and you are fairly healthy and you can get through an elective procedure, I think all those things would, it'd be probably the best treatment for a patient with atrial fibrillation compared to being on long-term medications, because you might avoid the need for needing a pacemaker in the future as well too, if we can control your AFib sooner rather than later.
Thank you. Another question, So, a lot of the signs and symptoms can be very major, of course, but what are some of the more mild symptoms that you see that you'd recommend someone to go see a specialist? Because, some of the mild symptoms are
So
common
yeah,
for
we
many
already know
things.
yeah, that's a great question too. We know the major, symptoms, usually palpitations, some shortness of breath, maybe chest discomfort. But I think a lot more what you would say more milder or more insidious symptoms that a patient might have could be shortness, could be fatigue, malaise. They just don't feel like their usual selves. I had a patient who was on a trip to Monticello apparently, and they were on a 5-hour bus ride, and she all of a sudden said, I just didn't really feel well. And luckily we had put a pacemaker in her, and lo and behold, she was in atrial fibrillation. And so it could be just something as, simple as I don't feel like I have the energy that I used to have as well too. So that might be something that you want to go see either a primary care physician for and or a specialist like me in electrophysiology to see if we can maybe put a long-term heart monitor on you for 2 weeks called a Holter monitor or some other type of heart monitor to see if you do have an underlying diagnosis of atrial fibrillation or maybe some other underlying heart arrhythmia as well too.
Great, thank you. Um, is an ablation considered an elective procedure?
For atrial fibrillation, most of the time, yes. The decision for an ablation is always on the patient because it is an elective procedure. But that's where you, as the physician, need to have a good conversation with the patient and a frank and honest one about what are the risk factors, why and why you should consider an ablation in your situation. And so all those things in line, I think you know, it really is an elective procedure in that sense because it really comes down to whether or not the patient really wants it or not, more so than anything. And I don't think there's anything more elective than that, essentially.
Great, thank you. And if you have any last questions, please ask them now. I see a question about when the session will be available for viewing. If you signed up for the presentation, it will be sent out via email in the coming days. Let's see.
I think I
Okay,
might have
well,
a. Oh, I thought I had my contact information if people wanted to. Unfortunately, I don't. I will have to add that next time, but I'm sure they can attach my contact information for my clinic in some kind of email or attachment with this session as well too. So if anyone has any questions, I'm more than happy to just answer questions too. Whether or not you see me in person, that's that's obviously up to you, but more than happy to at least answer questions at any time.
thank you so much, Dr. Ahmad. This has been very insightful, and it's exciting to see the future of things such as what you're doing, and it's great to hear the research that you've done. So thank you all for being here this afternoon. And I hope you have a great rest of your day.
Appreciate it. Thanks for taking out your time to come and listen to this. And if you need anything, please reach out. I'm always here to help. Thank you.
Great. Thank you so much.